Good afternoon, sir.
Okay. So, uh, please, the last time we met, did we talk about the female external genitalia?
Yes, sir.
Yes, sir.
We talk about the external genitalia.
Yes, sir.
Okay. Then it means that we finish with the female.
Yes, sir.
Yes.
Yes, sir. Sir, we have completed a female distance. So
Okay. So, then that is nice. I think we also talk about the blood supply, did we? Did we look at the blood supply? Hello, I'm asking a question.
no, no, sir, please.
No, sir.
Okay. Uh, hmm. Okay, so we are going to do it this way. And please, you try and bear with me. I think you get everything that I'm trying to say. Okay. Now I'm just going to do some, just a short overview. So please, forget about the details. Uh, just a short overview of the pelvic what. So we are looking at this one this way. We are looking at the main the blood supply to the pelvis. So if you look at this one here, this is the pelvic cavity. So this is the abdominal aorta. This is the abdominal aorta. What I want you to note here is that the abdominal aorta bifurcates at the level of, I think, L4. It will bifurcate to common what iliac what artery. So that's the right common iliac, and that's the left. Then a common iliac will bifurcate into internal iliac, then external what iliac. The external iliac is passes behind the inguinal ligament and becomes the femoral artery. So the femoral artery is a continuation of the external iliac artery at the thigh. The femoral artery is a continuation of the external iliac artery at the thigh. The internal iliac, this one here, this internal iliac is the artery that supplies the pelvis. Supply the pelvis what cavity, and the pelvic wall, the pelvic viscera. Then it even supplies the perineum. It also supplies the perineum. Then it also supplies the gluteal heart region. It also supplies the gluteal heart region. Because whatever we have touched on is the pelvic what viscera. Of course, we look at the female reproductive system. We've also talk about the male reproductive system. So if you're looking at the pelvic viscera, then you should be thinking about the internal iliac artery. You should be thinking about internal iliac artery. Then, of course, a branch of the internal iliac artery will supply what do you call it, the perineum. So this is the branch that is going to supply the perineum. This one, the internal pudendal artery. Now, so the artery to the pelvis. So the main artery is coming from the what? Internal what? Iliac what? Artery. So this is the one that I want you to remember. Okay, very, very, very what? Important. Now, if you are looking at the reproductive organs, then of course, we also touch on the gonadal what? Arteries. The gonadal arteries, that means the ovarian artery or the testicular artery, which will be coming from the abdominal what? Aorta. Then if you look at here, you can see this branch here, the median sacral artery. This one is the inferior mesenteric artery. You see it continuing down to supply the rectum. Of course, the rectum is found in the what? In the pelvic what? Cavity. So here, I'm trying to do some kind of regional anatomy here, not so much on the systemic. So that is why, because in front is the bladder, behind is the, so if you look at this one, this would definitely be a female. So this would be the urinary bladder will be here, the rectum will be here, then in between you have the uterus. If you are to the uterus, you have the vagina. So there's blood supply to the bladder and to the rectum. You have it also being supplied by the internal iliac and also from the inferior what? Mesenteric what? Artery. So let's look at the branches of the internal iliac artery. This internal iliac and this is external. The internal iliac artery, it has two main divisions. This is the posterior division, and this is the big anterior division. The posterior divisions, they don't supply any pelvic viscera. They supply the wall. So you have something, this one is the iliolumbar. You have this one, the lateral or sacral. Then this one here, that is going to the buttocks, is the superior gluteal artery. This one here. They are showing, they are not naming it here, but they are naming it over there. This one. So that's the superior gluteal artery. So in terms of the pelvic viscera, it doesn't supply any of the organs. The viscera, it also supply just the wall. Now, if you're looking at the anterior division, then of course you'll be talking about those that supply the viscera. And in anterior division, the name that they bear is very, very simple. You have the one that supply the rectum will be rectal arteries. The one that supply the uterus will be uterine artery. The one that supply the vagina will be the vaginal artery. I'm trying to stick to my systemic approach. Okay. So we are looking at the female reproductive system. So what we'll be thinking about, the uterine artery. You'll be thinking about the vaginal artery. And so those are the arteries that we'll be interested in. And I'm saying that these arteries are coming from the internal iliac artery. Okay. Then I want you to look at here because I'll also be talking about it. This one here, the internal pudendal artery, is the one that supplies the perineum. They supply the perineum. And this is the internal iliac artery. And whatever I'm going to talk about, please watch the internal iliac artery. This one, it runs with this nerve that we call the pudendal nerve. Now, this is ischial spine. This is a sacrospinous ligament. So this notch, big notch here, is what we call the greater sciatic. This foramen is the greater sciatic foramen, and the foramen here is the lesser sciatic foramen. So here you can see the internal pudendal artery passing behind the sacrospinous ligament, then also through the lesser sciatic foramen. Then it will enter the perineum. There's another thing that I'll add later. It will enter the perineum. Remember, this artery runs with the pudendal nerve. Runs with the pudendal nerve. Okay. Another thing that I want you to note here is this. Let me see. One thing I want you to note here is this: the lumbosacral plexus. The lumbosacral plexus. So still we are in the pelvic cavity. So L5, L4, L5, S1, S2, S3, S4, they form the lumbosacral plexus. The lumbosacral plexus. The interesting nerve that the nerve that we are interested in this is this one here, the pudendal nerve. So from S2, S3, S4, there's a nerve that emerge. The anterior rim of S2, S3, S4 form this pudendal nerve. And I told you that pudendal nerve runs with the internal iliac the internal pudendal artery. N is the artery to the perineum. Is the artery to the perineum. Okay. So here you can see the internal pudendal artery and you can see the pudendal nerve. So the nerve to the perineum is the pudendal nerve. Then the artery to the perineum is the internal pudendal artery. Okay. So these are actually the nerves that will be coming from the sacral plexus. This will be a nerve that will be coming from the sacral plexus. And if you look at all these nerves, these plenty nerves, then the nerve that stands out is the pudendal nerve. And the other one that stands out is the posterior cutaneous nerve of the thigh. It's a cutaneous nerve. So we'll see that it supplies some part of the scrotum, the labia majora. The labia majora, we are looking at the lateral posterior to third part of the labia majora. They are supplied by the posterior cutaneous nerve of the thigh. So I repeat, for the sacral plexus, the nerves that we are interested in are the pudendal nerve and the posterior cutaneous nerve of the thigh. Now, this is the pudendal nerve. This is the pudendal nerve. We see that from anterior rim S to S3, S4, passing behind the sacrospinous ligament through the lateral sciatic foramen, and then enter the perineum to supply it supplies most part of the skin of the perineum and also the muscle that you find there. Okay. The muscles that you find there. Okay. Now, I realize that the slide that I gave to you is a lot. So let me use a simplified version that I have here to teach you. Okay. Okay. So I think this one is better. I hope you can see the slide.
Yes, sir. Yes, sir.
Yes, sir.
Okay. If you can see the slides, that is nice. So we are looking at female reproductive system. We've done this one. So we started our discussion on the ovary. So this will be the blood supply. And we know where it's coming from. Look at here, the anterior division of the internal iliac artery. So the ovary, the blood supply is from the ovarian artery. And the ovarian artery is from the abdominal what aorta is from the abdominal aorta. The ovarian artery lies within this ligament, which you also know, the suspensory ligaments of the ovary, what you also call the infundibulopelvic ligament. So it's a peritoneal fold that is attached to the ovary. So you should remember that the ovarian artery lies within the suspensory ligament of the ovary. You see, after supplying the ovary, it also gives branches to supply the uterine tube. It also gives branches to supply the uterine tube. Then this is the uterine artery, the artery to the uterus. And you can see here that it gives branches to supply the vagina, and it also gives branch. So here you can see the uterine artery give branches to supply the vagina. It also gives branches to supply the uterine tube. Now, you should remember this relation when we look at the urinary system. We talk about it. Water under the bridge. The uterine artery crosses the ureter. Then this is the branch that we call the vaginal artery. The vaginal artery supplying the vagina. You can see that it also has a branch from the uterine artery that supplies the vagina. So you realize that with the females, if you're looking at the viscera and their blood supply, it's very, very, very simple. It's very, very simple. And so this was when I was talking about the uterus. Now, in terms of the innervation, what I want you to remember is that because we are looking at smooth muscles and we are looking at smooth muscles and we are looking at glands, then we should be thinking about the autonomic nervous system. Then we should be talking about the autonomic nervous system. So then, because the female you are talking about the external genitalia, then you also be talking about the somatic nerves. And here for the somatic nerves, we'll be interested in the pudendal nerve. We'll be interested in the pudendal nerve. So in terms of the innervation, autonomic innervation, then somatic innervation, then sensory innervation, visceral sensory innervation. Because when there's pain coming from the ovary, when there's pain coming from the uterus, that one too must be what? That one too, we have to mention it. So there's also going to be what? Visceral sensory innervation. Okay. Now you listening to what I'm saying. You see the screen. You see the screen. So you see the screen. So you just pay attention. Okay. Okay. Please, can you see the screen now? Why is this one showing like that? So autonomic innervation, somatic innervation, and lastly, visceral sensory innervation. So those are the things that you will have to look at. So I repeat again, there is somatic innervation, there's autonomic innervation, and the visceral sensory innervation. So I hope you can see the screen now.
Yes.
Please, I hope you can see the screen now.
Yes, sir.
Yes, sir, we
Yes,
can.
sir.
Okay, so I'm going to talk about those three. And please, I'm going to be very brief about that. So just I don't want to confuse you. So just pay attention. Just pay attention to that one. So let's start with the autonomic what innovation. So the autonomic innovation. So in terms of autonomic innovation, it is this plexus that we are interested in. We call the inferior what? Hypogastric what? Plexus. The inferior hypogastric plexus. They also call it the pelvic what? Plexus. They also call it the pelvic what? Plexus. Now, if you look at the color here, you realize that it's what? It's mixed. It contains both sympathetic and parasympathetic what? Nerves. It contains both sympathetic and parasympathetic what? Nerves. Yes, it's in fact it's even contain visceral what sensory what nerves. Aha. So that one is very, very important. Now, so remember this nerve. So it's carrying both sympathetic and what? Parasympathetic. And also carrying what? Visceral what sensory what fibers. So the inferior hypogastric what plexus. In the females, there's a very important plexus arising from the inferior hypogastric plexus. There's very important plexus arising from the inferior hypogastric plexus. That plexus is what we call the uterovaginal plexus. The uterovaginal plexus. In males, we talk about the prostatic plexus. The prostatic plexus. I remember when I was talking about ejaculation, I mentioned the prostatic plexus from which you have the cavernous nerves. Those ones that will lead the nitric oxide. So in terms of the innovation, autonomic innovation of the female pelvic viscera, you need to remember the inferior hypogastric plexus or the pelvic plexus, which will give rise to what we call the uterovaginal plexus. The uterovaginal plexus. So think about that one. Then think about that one. So I mentioned that let's look at the visceral sensory fibers. This visceral sensory fibers. Please, that one too is very important. The visceral sensory fibers. In other words, as I said, if there's pain coming from the uterus, if there's pain coming from the upper part of the vagina, if there's pain coming from the ovary, they will travel along either sympathetic or parasympathetic fibers. They will travel along either the sympathetic or parasympathetic fibers. So we're also interested in what? Visceral afferent fibers or visceral is sensory fibers. They relay sensory information, a primary pain from the pelvic organ. And I'm saying that they travel either to the sympathetic and parasympathetic. So there is something that we call the pelvic pain line. So this one is what we call is a pelvic pain line. Now above the pelvic pain line, those structures that are in contact with the peritoneum, the pain sensation, they travel along the sympathetic pathway. They travel along the sympathetic pathway. Then those below the pelvic pain line, they travel along the parasympathetic pathway. The parasympathetic pathway. Now, for your information, for the female reproductive organs, the sympathetic nerves will be coming from T10 to L2 segment of the spinal cord. I repeat, the sympathetic pathway, the nerves will be from T10 to L2 segment of the spinal cord. The parasympathetic will be the pelvic splanchnic nerve, S2 to S4 segment of the spinal cord. So that one important. Below the pelvic pain line, they travel along the parasympathetic nerve pathway. Above the pelvic pain line, they travel along the sympathetic pathway. So that point too, I want you to remember. Then finally, I was talking about the one that supplies what? The perineum. Okay. So with that summary, then let's go back so that I show you one or two things. Okay. So okay. I've seen something here. Okay. So let's look at this one. So under the ovary, we are looking at the innervation. We are looking at the blood supply, and we are looking at the lymphatic drainage. So both the ovary and the testes are the gonads, and their blood supply is all coming from the abdominal aorta. So I've already touched on the blood supply to the ovary, to the vagina, to the uterine tube, and to the uterus. So I'm not going to go into that. Now, the lymphatic drainage, they follow the ovarian artery. So it means that it will drain into the para-aortic lymph nodes, just like the testes. Now, in terms of the autonomic innervation, the sympathetic fibers will be coming from T10 to L1. And for the ovary, please, there's nothing like utero-vagina.
This year,
Ovary, yeah, Abigail, yeah. For the ovary, the utero-vaginal plexus is nowhere, because we saw that where the utero-vaginal plexus is. It's in the what? The pelvic viscera. This one, there's a plexus involved, is what we call the ovarian plexus. The ovarian plexus is from the renal or aortic plexus. I think when we're looking at the kidney, we mentioned those plexus. So they are the one that is responsible for what? Vasoconstriction, follicular development. Now, if you look at where the ovary is, it's above the pelvic pain line. So pain that is coming from the ovary will travel along the sympathetic pathway. The parasympathetic innervation, its rule is not clear. So that's all that we have to know about the ovary. For the uterine tube, once again, we touch on a blood supply. So I'm not going to go into that one. The uterine artery has blood supply coming from the ovarian artery. Even the uterine artery, they all supply the uterine tube. Now, the lymphatic drainage. Now, the infundibulum is closer to the ovary. So lymph vessel from the infundibulum and the ampulla they follow the ovarian vessels, so they also drain into the para-aortic lymph node. Elsewhere, they drain into the internal iliac nodes. What it means is that if you are looking at how cancer spread and the lymph nodes that will be involved, and you are talking about the uterine tube, if it is affect the infundibulum, then of course the first lymph nodes, the sentinel lymph node that will receive the cancerous cells will be the para-aortic lymph nodes. That is exactly what this one means. In terms of the innervation, once again, we are talking about sympathetic and parasympathetic. Remember what I said about parasympathetic? It's coming from S2 to S4 segment of the spinal cord. And the sympathetic was coming from T10 to L2 segment of the spinal cord. So the sympathetic fibers will regulate vasoconstriction. Then remember, within the uterine tube, there are some smooth muscles there. So smooth muscle contraction, it will be under the sympathetic nervous system. Okay. Now, if you look at the uterine tube, it's also about the pelvic pain line, and it's in contact with the peritoneum. So pain from the uterine tube will travel along the sympathetic pathway, and the pain will be referred to an area corresponding to the T10 to L2 dermatome. So that is what you also need to know over there. For the uterine tube, from the uterus, we've already touched on the blood supply to the uterus. The lymphatic drainage to the uterus, the fundus of the uterus also goes into the para-aortic lymph nodes. From the body and the cervix, they drain into either the external iliac or the internal iliac lymph nodes. The sympathetic and parasympathetic innervation, as I said, you should remember the uterovaginal plexus. The uterovaginal plexus. Sympathetic nerves will be responsible for vasoconstriction. Then what do you call it? The uterine contraction. Now, but it's also important for you to note that when it comes to the activity of the uterus, is controlled mainly by hormones. It controlled mainly by hormones. Not so much about the sympathetic and parasympathetic fibers. Once again, the uterus, the fundus of the uterus, also above the pelvic pain line. So pain will be traveled along the sympathetic pathway. Then finally, we have the vagina. Now, the vagina, if you look at the lower part of the vagina, lower 1/3 of the vagina. So the vagina, let's divide them into lower 1/3. And so, okay, let me stick to this one. So lower third, then so lower 1/3 and upper 2/3. So let me put it that way. Now, if you look at the lower 1/3 of the vagina, that one is in the perineum. That one is in the perineum. That one is in the perineum. This is how come, if you look at the upper 2/3 of the vagina, lymphatic drainage is to the internal iliac lymph nodes. But then the lower third of the vagina, it goes to the superficial inguinal lymph nodes. Now, the upper part of the vagina, so here I should rather say upper 2/3 of the vagina, they are innervated by autonomic nerves. They are innervated by autonomic nerves. The lower third of the vagina are innervated by somatic nerve, and here we are looking at the pudendal nerve. The pudendal nerve. So it means that the lower part of the vagina will be sensitive to pain. It will be sensitive to touch, and it will also be sensitive to what? Temperature. Unlike the upper tutorial vagina, which is innervated autonomic nerves, so is sensitive to what? Stretch what? Sensation. It's sensitive to stretch what? Sensation. Okay. So that is the few points that I want. I just want you what to note. To help you appreciate this point, I'm going to do. But if you have any question, you can ask the question. I'm going to do something small so that at least. But if you have a question,
Welcome, Brown.
uh-huh. Hello.
Hi, sir.
Okay. Any question?
So we have some in the chat box.
Okay. So I have. So is it true if the female stay away from sex for a long time, away from sex for a long, will experience vaginal dryness? Does the vagina get spasm? Please, there's a condition called penis catweb. The penis gets stuck in the vagina. Please, do females ejaculate? And which artery is used in abdominal and renal dialysis? I don't understand the last question. What do you mean by which artery is used in abdominal and renal dialysis? Your use of the word abdominal and renal dialysis. That's what I'm interested in. Uh-huh.
So I'm sure she's trying to ask when they pass a femoral catheter for dialysis. I'm sure that's what she's trying to ask, not the this and the.
Okay, please give me a minute.
Sir, sir, please, I have a question.
aduane bebree si ade yɛɛfɔ kɔ yɛnoa ne ma yɛ na kere meka sɛ dwa bankye tere bankye mekɔ na watu
Mute
Roberta,
yourself.
mute yourself.
Roberta,
Ah,
mute yourself.
Roberta, banche no ubetosen.
Okay. Sorry, I had to attend to something. So I think one lady was trying to explain what the question that the person was asking. Hey, someone is talking about fufu.
Sir, please, I have a
Mhm.
question. The
Yes.
the innovation, the lower one third, in your points, I could see sharp pain and temperature. Please, the temperature bit, can you explain it for me? Like with the women especially, is it that we feel, I mean, you feel that the vagina is hot or cold, or usually it happens when the women are trying to steam the vagina and like those vaginal steaming thing that the women do. Thank you.
Okay, so so there I'm just trying to explain that uh if I say somatic nerve, so it's like you're talking about the body wall. So I'm just trying to say that they are just as they are pain receptors, we also have these temperature what receptors. They have touch what receptors. So those are the things that I'm talking about. So of course, anything that has to do with ability to detect what temperature changes, what we are saying that one can be done. Unlike what they call it, uh, the autonomic what nerves, they don't do that. That is what I mean by that. We'll be doing. I'll talk about the pelvis and perineum, but someone was also asking about fufu for no. Uh, please do females ejaculate? Yes, the female too release something. Uh-huh. But I don't. Females also release something. Doing you are talking about doing orgasm. So the answer will be yes. And you when we're looking at the the external genitalia, I think we mentioned something like the greater what? Uh, we mentioned something like the greater what vestibular what gland. And I think we also mentioned when we're doing the urinary system, we mentioned the power urethral what glands. The power urethral glands. Then you can also the power urethral glands opens into the external urethral orifice. So those are the ones that if you can mistaken it to be that it is what urine, but that one is not urine. But of course, apart from the greater vestibular glands, there's also the lesser what vestibular what glands. All those ones release something. So if you are talking about ejaculation, yes, they do, and the secretions are for the glands that I have talked about, particularly the power heart urethral heart glands. Okay, now that the vagina also get spasm. Of course, then you are talking about uh, I'll be touching on what they call it. Uh, the perineum very soon. So maybe I'll touch on that one. Then the vagina dryness. So it's that if the female stay away from sex for a long, will experience vagina dryness. If you look at vagina dryness, it's a whole lot of things. It's a whole lot of things. Of course, it's controlled by what? Hormones. So you realize that when you postmenopausal women tend to experience what? A lot of what? Vaginal what dryness. Hey, someone is making a. So medication can also cause vaginal what dryness. So not having sex for a long time. I'm not sure will be a major contributing factor. Unless of course I'm not sure that one will have a major contributing factor.
Sir, please, I have another question.
Yes, ask your question.
I with a sharp pain, so the lower one third is where you talked about the sharp pain. So I'm imagining that it should be when the woman is having sex with a man, and maybe the woman is going through some pain. But what about when the woman is menstruating and going through pain? Does it still come? Does the pain still come from the lower one third, or that one's inhibition is different? Thank you.
Have you done the physiology? Have you
Not
done
yet, sir.
physiology here? Reproductive
Not
physiology.
not yet, sir.
Okay. So if you look at here, you don't have anything much happening if the person is menstrual flow. Because menstrual flow, yes, it's passing to the vagina orifice. But I'm not sure the blood, the flow that is coming is what's actually causing the pain. The pain is actually from the uterus because it is the endometrial lining that is being the functional layer of the endometrium that is being shed. And yeah, I remember when we're looking at the uterine cycle, I mentioned something like when the estrogen level goes down and progesterone goes down, I said that prostaglandins are released. And these prostaglandins, they actually are the one responsible for that strong contraction that help in the shedding of the functional layer. So you realize that the pain will be coming from the contraction of the uterus due to the prostaglandins being released, not the blood that is flowing through the vagina. If you are talking about maybe the lower part, the vagina also being part of the birth canal, and you are talking about a pain doing delivery. Then of course, then that one will play a very role in terms of the pain that the person experiences, not only during the intercourse that you are talking about, but from vaginal delivery, especially when the baby is passing through the lower one third of the vagina. So, hey, someone is saying that the penis captivus, where the penis gets stuck in the vagina. Why do you think the penis get stuck? We are not like what do you call it? Hmm. We are not like dogs.
Dog.
So uh so what will cause it to happen? Will definitely be tied to the vaginal spasm the person is talking about. But then the anatomy of the dogs, it is what is responsible for the situation where you get the vagina and the penis still inside the female vagina, and that it takes some time before those they are able to what separate. But that one doesn't happen in males. If it does happen, as you are calling the penis captivus, like the penis, the vagina is capturing the penis, then that one is just like our sister was talking about, the vagina spasm that is happening. So of course, another thing that I'm going to talk about is what do you call it? We are going to look at the pelvic floor muscle. There's a technical term for the vaginal spasm, what they call the vaginismus, the vagina. So vagina, vaginismus. So that is a technical term for the spasm, the vaginal spasm. So in terms of, so this one is not something that should happen. That should happen. And it has more of a psychological factors. So of course you have contraction, involuntary contraction there, and that is what is responsible for the spasm that you are talking about. So maybe probably when there is this vaginal spasm, that is when maybe the penis then is not, the penis gets stuck. As a result of the contraction. That is why the penis probably gets stuck. It's not, even if it's okay, it's rare. It's rare. It's not a normal occurrence. Blue balls, in case they want to chop and they didn't get that one, unless we ask the females. I've not heard about. You see, the blue balls in males, that is what do you call it? That one has to do with the epididymis, and females do not have epididymis. So maybe what females will have, maybe it may be different. Okay. Now we're looking at the pelvic cavity. There's a note that I gave to some students I recently taught, and I think I tried to let me continue here and also show something here with respect to the females. There is this diamond-shaped area here we call the perineum. So I'm trying to draw it. Let me use something blue. So this is the perineum. This is the perineum. So this diamond-shaped area is what we call the perineum. So there is a pubic symphysis. Anteriorly, posteriorly, there is a coccyx. Anterolaterally, we have this bone here, the ischopubic rami, singular ramus, the ischopubic ramus. The reason is that this side here is the ramus of the ischium, and this side there is the inferior pubic ramus. Is the inferior pubic ramus. So, and this is the ramus of the ischium. So when you put the two together, it becomes the ischopubic rami. So then laterally, we have these ones, the ischial tuberosities. These are the ischial tuberosities. Then posterolaterally, we have this one here, this ligament here, the sacro. No, it's not this muscle. There's another muscle. Please, if you look at here, this is coming from the ischial spine. I'm not talking about that one. There will be a muscle coming from here, the ischial tuberosity. So that will be the sacrotubulus ligament. The sacrotubulus ligament. So I repeat, anteriorly the pubic symphysis, Anterolaterally, the ischopubic rama, laterally, the ischial tuberosity, posterolaterally, the sacrotuberous what? Ligaments. Then posteriorly, we have the causes. So this diamond-shaped area is what we refer to as the perineum. Then there is an emergent line connecting the ischial tuberosities. There's an emergent line connecting the ischial tuberosities. So you can have this will be the line connecting the ischial tuberosities. Yes. So that you're going to have two triangles. The anterior triangle, then the posterior triangle. The posterior triangle is the inner triangle. The posterior triangle is the inner triangle. So in the inner triangle, we have the inner canal, or called the canal, open out through this opening that we call the anus. Then on either side of the inner canal, you have a fat-filled space here. Here is filled with a lot of fat. We call the ischoinner fossa. The ischoinner fossa. So at the inner triangle, there is the ischoinner fossa and the inner canal. So this is the anus. Okay. Then the anterior triangle is called the urogenital triangle. Is the urogenital triangle. The urogenital triangle. Urogenital triangle because uro means if this is the female, so you see that this is the opening of the heart. This is the external urethral meatus. So that's the urethral aspect. The genital aspect, of course, here you can see the vagina over here. So the anterior triangle is called the urogenital triangle. The posterior triangle is the inner triangle. This diamond-shaped area here, if we mentioned the pelvic inlets. So this diamond-shaped area, the boundaries will also form the so-called pelvic outlets. The so-called pelvic outlets. Now, here you have this. There's another thing. You see this place here, this side here. This area between, which is the midline connecting the two ischial tuberosities, or the midline between the vaginal orifice and the inner one, the anus. This is also called the gynecological perineum. The gynecological perineum. So that is the gynecological perineum. And there you have so this fibromuscular mass is called the perineal body. This is a perineal body. This perineal body is very important because that is where you have a lot of muscles inserting on this perineal body. Here you can see the external. You can see the external inner sphincter inserting on the perineal body. You have the bulbous spongiosus muscle inserting on the perineal body. Then these transverse perineal muscles, both the superficial and the deep one, all inserting on this perineal body. So the perineal body is very, very important, providing support to these important muscles. You realize that when there's a damage to the perineal body, it can lead to prolapse. It can lead to prolapse. Now, I'm showing this image here because I only wanted to talk about the nerve that supplies the perineum. Then nerve is what we call the pudendal nerve. The pudendal nerve. Now, this pudendal nerve is also the nerve. Remember, when we're looking at the inner canal, we said that there is an external inner sphincter and there is an internal inner sphincter. The internal inner sphincter is a smooth muscle. The external inner sphincter is a skeletal muscle. That external inner sphincter is supplied by the pudendal nerve. Then when we're looking at, once again, the external uterine sphincter is a skeletal muscle. The internal uterine sphincter is a smooth muscle. The external uterine sphincter is also supplied by this pudendal nerve. This pudendal nerve will supply the transverse perineal muscle. It will supply the bulbous spongiosum muscle, and will also supply the ischiocavernosus muscle. So you realize that in males, we also had the bulbous spongiosus muscles. Those muscles that were covering the bulb of the penis. In females, they also have bulbous spongiosus muscle covering the bulb of the penis and the greater vestibular glands or the Bartholin's glands. Now, this is a glans of the clitoris. This is the body of the clitoris, and this is the leg of the clitoris. So the leg or crus of the clitoris is also surrounded by this ischiocavernosus muscle. So all these muscles are supplied by this pudendal nerve. The pudendal nerve does not only supply the muscles over here, the muscles that you just mentioned. It also give innervation. It's also supply the skin. The skins around the perineum. The skin around the perineum. And in this image here, this area that they've colored, this area here, plus the area here, the skin is actually supplied by branches of the pudendal nerve. Are supplied by branches of the pudendal nerve. So, in terms of the motor innervation of the pudendal nerve, I'll mention the external inner sphincter. I'll mention the transverse perineal muscles. I'll mention the bulbous spongiosus, the ischiocavernosus, then the external uterine sphincter. So everything, this compressor uteri, the utero-vaginalis, they are all motor supply from the pudendal nerve. Now, this one is showing you the pudendal nerve, the branches and the part of the skin that it supplies. So you see that it's inferior rectal nerve. So this area here, the skin is supplied by a branch of the pudendal nerve. Then the posterior labial nerve. So this the posterior labial nerve. So that one also being supplied is also from the pudendal nerve. Then there's the dorsal nerve of the clitoris. So the skin around this area too they are all supplied by the pudendal nerve. But then if you look at here, this area where you have the mons pubis and some part of the labia so here the color, the way they've done the coloring, it's not perfect, but we'll take it like that. Some parts, remember, it's not only this part, some part of the labia majora and the mons pubis. The skin here is supplied by the ilioinguinal nerve. The ilioinguinal nerve. Then from the sacral plexus, I mentioned that there's a posterior cutaneous nerve of the thigh. It also gives branches to supply this area. So if you look at the perineum, the diamond-shaped perineal region, the skin there is not supplied everywhere, not supplied by branches of the pudendal nerve, but also branches from the ilioinguinal nerve, branches from the genitofemoral nerve, and branches also from the posterior cutaneous nerve of the thigh. Now, all these one are important because there's something that we call pudendal nerve block. So this one, what is being done? Just another minute. Yeah. I'm sorry. Yeah. Yeah. My daughter is sick, and when they're giving her medicine, she doesn't want to take it. When she sees me, then she takes it. Uh, so that's why I've been going. Okay, so that's the pudendal nerve. And I've shown a very important relation. The pudendal nerve passing behind the sacrospinous ligaments. So you see, this is a pudendal nerve block. Okay. So you have this approach. So here is trying to palpate the ischial spine. So, and we know where the nerve is. So you can have transvaginal approach and also have perineal approach. Okay. But when you do pudendal nerve block, you see pudendal nerve is from S3, S2, S3, S4 segment of the spinal cord. So when you do pudendal nerve block, you are actually blocking those nerves from there. So the anesthesia will just be on the lower 1/3 of the vagina, some part of the perineal skin. So those areas here that as I told you are from the pudendal nerve. So those places. So it's very, very good, what do you call it? When they are doing episiotomy or minor perineal surgery. Okay. It does not block uterine contraction. Because uterine contraction, you're looking at 10 to L2 segment of the spinal cord. So when you do pudendal nerve block, because of vaginal delivery, that one you are still going to feel pain. That is coming from what? Uterine contraction. Okay. So the best approach, if you really want to, is when you do spinal anesthesia, where the anesthetic agent is rather released into the lumbar system. The lumbar system, between the dural arachnoid meter and the pia meter, we have the subarachnoid space. Large subarachnoid space are called cystine. Large subarachnoid space are called cystine. So the anesthetic agent is released into the lumbar systems between L3, L4, between L4 and L5. So of course, when you release an anesthetic agent high up that way, it means that all the nerves below, you block all pain. Block all pain coming. That means the uterus, cervix, vagina, and the entire perineum. So this is better than doing vaginal delivery. And of course, when CS is being done, of course, it is the one that is usually done. Okay, so that is just on that. Then there's another thing that you also need to know. There's another thing that you also need to know. And let me look at the slide that I gave you. The slide that I gave you. So we can use that one to talk about. So let's look at this. Let me look at the slide that I gave you. I'll attend to the questions that you have there. Yes. So I gave you this slide. I'm hoping, yeah. Okay. Okay. So this is another thing that I wanted to talk about. So let's also talk about this one. Oh, what is happening? What is happening to me? Okay. So this is better. So we also need to know this one. What is happening? Okay. Yeah. Now, there's a part that I want you also want to talk about. Now, if you look at the pelvic cavity, the floor, the muscle that is forming the floor is what we call the pelvic diaphragm. The pelvic diaphragm or the pelvic floor muscle. The pelvic diaphragm. So the pelvic diaphragm is the muscle that forms the floor of the pelvic cavity. And there are two muscles. There's a levator inner muscle and there is a coccygeus muscle. So let me show you the image proper. Once again, this is sacrum. This is the two hip bones. So these muscles here forming the pelvic floor is what we refer to as the pelvic diaphragm. The pelvic diaphragm. Let me put some numberings over there. So I'm naming this one 1, then this one here as 2, then this one here as 3. Okay. So the pelvic floor muscles, 1, 2, and 3 are collectively called the elevator inner muscle. 1, 2, and 3 are collectively called the elevator inner muscle. Then this one here, coming from the ischial spine, this one is called the coccygeus muscle or the ischio-coccygeus muscle. So the ischio-coccygeus muscles and the elevator inner muscles are what we call the pelvic diaphragm. Here, the elevator inner muscle is made up of 3 parts. There is this one here that looks like is U-shaped. This one here, going around the rectum. This one here is called the pubo rectalis. The pubo rectalis. This one here is the pubo-coccygeus, and the 3 is the ilio-coccygeus. So the pubo rectalis, the pubo-coccygeus, ilio-coccygeus, they are collectively referred to as the levator inner muscles. And the levator inner muscle, together with the coccygeus, constitute the pelvic floor muscles. So they are the ones that support the pelvic viscera. And of course, you see that the rectum pierces it to become the inner canal. The vagina is piercing it. And of course, the urethra also pierces this pelvic diaphragm. Okay. There are other functions of the pelvic diaphragm. There's this one, let me not forget it. You see this pubo rectalis. Pubo rectalis. It forms a U-sling. This is it, the pubo rectalis. It keeps the rectum angle at the rectal inner junction or the anorectal junction. It is because of this puborectalis muscle. That's why now you have this kind of argument going on that, of course, the proper way actually to sit on a WC this way. The squatting is a proper way of defecation. So if you can't squat because you are using water closet, then it means that you have to put your legs on maybe a plastic chair, so that you have this kind of angle here. So the pubis rectalis, when you squat, is relaxed, and the rectum straight, so that the defecation becomes very easier. That one is better than when you are sitting, where the anorectal junction is narrowed. The anorectal junction is narrowed. So if you look at the functions of the pelvic diaphragm, yes, it's a support the pelvic viscera. It supports the pelvic viscera. And when there's too much intra-abdominal pressure, it resists it. It resists the pressure, and the increase in pressure is actually what is responsible for defecation, urination, and delivery, and also lifting heavy objects. So that's the pelvic viscera. Now the muscle here, the obturator internus muscle, and the muscle here, the piriformis muscle, they are not muscles of the elevator. They are not muscles of the pelvic diaphragm. This is a piriformis muscle. Look at where it's going. And this is the obturator internus muscle. Look at where it's going. It's going to the what? The femur. So they are actually muscles of the hip. They are actually muscles of the lower extremity. They do not constitute the pelvic diaphragm. They do not constitute the pelvic diaphragm. So that point is also very important. Now, the last point that is important is this one here. I think I usually have Now, so look at this one here. This net here, imagine this net here to be the pelvic diaphragm, supporting the pelvic viscera. Okay. Now, if you look at the uterus, the cervix of the uterus and upper part of the vagina, there are some ligaments. There are some ligaments that connect to the body wall. The thing that connect to the body wall. I mean the bony pelvis. So you have ligaments like there's a let's say there's a cervix. So of course the cervix, the cervix and upper part of the vagina, you have ligaments from here laterally, the transverse cervical ligament. The transverse cervical ligament has several names. We also call it the cardinal ligament, or this name, the McEncroft ligament. So they are from the lateral pelvic wall to the lateral cervix and upper vagina. Then in front, there is connection to the pubic mole, the pubo-cervical ligament. Then also to the back, we have the uterosacral ligament. So when it comes to support, it's not only the pelvic diaphragm that provide support. These pelvic ligaments also provide support. The pubo-cervical, the uterosacral, and the transverse cervical or the cardinal ligaments. So when you're looking at the uterine supports, the primary uterine support is the cardinal ligament and the uterosacral ligaments. Of course, secondary report will be this one here, the round ligament of the uterus. Then you have here overall pelvic supports. I mentioned the perineal body, and I also mentioned the pelvic diaphragm. So when you look at this one, you realize that when there's a problem with this pelvic diaphragm, and when there is also problem with those ligaments, the uterosacral, the transverse cervical, and the pubo-cervical ligaments, then it is going to lead to what? This prolapse. It can lead to this prolapse. So here you see the vagina, the bladder falling into the anterior wall of the vagina. Then the rectum will fall into the posterior wall of the vagina. Then you have uterine prolapse, where the uterus will fall into the vagina. So you can have all these things happening as a result of weakness in the pelvic floor diagram. So we have it here. The elevator ani and the pelvic ligament can be torn, causing pelvic floor dysfunction. So the obstetric factors are multiparity, prolonged labor, and as the main factors. Of course, you can have non-obstetric factors. Now, once again, let's look at prolonged labor. Prolonged labor too can lead to fistula. So because when there's prolonged labor, the blood supply here between the uterus and the rectum, and between the uterus and the bladder, the blood supply here will be cut off. Remember, there are tissues here, septum, separating the viscera. So when those become compromised, those soft tissues there, when they become compromised, then of course you have abnormal connection being created. So you can have vesico-uterine fistula, vesico-vaginal fistula, and rectal vaginal fistula. So you have urine and urine feces all passing through the vagina. So those things can also happen. Some culture, if you have sex with someone, this one is a bit, you eat 6 bowls of kinky one for breakfast and complain vaginal dryness. So what should the person eat? Of course, so the vaginal dryness, as I said, is hormonal a lot. Then it also means that such a woman, when the man is actually sleeping with you, you have to be activated a lot. The foreplay should be massive, so that hormones, all the hormones that need to be released will be released, so that all the secretions, the para uterine gland, the lesser vestibular glands, the greater vestibular, they can all release their secretions, so that you don't have vaginal dryness. Of course, if you also look at the whole concept of vaginal dryness, you realize that it also depends on the time of the menses, the time of the menstrual cycle that you are in. So that one too is something you should be aware. Hey, Asemo, I was thinking that some questions have been there, but it looks like please, a client complained to me that she feels nothing when she has. Does it? That's her husband. Please, could it be put under the supply? She feels nothing. Wow, what do you mean that the person feels nothing? The person is not enjoying the sex. Or someone with their hand, the person can ask the question, but then when you say you feel nothing, because you see, sex is I would say greater percentages is the brain. So maybe I don't know what the person is thinking about. So if you can do a proper foreplay and get the brain activated, so that the person will be thinking, I mean, if you have serious maybe exams that you have to write, that one I'm not sure, or maybe there's a deadline. There's the deadline that you don't want to miss. That one, and even your wife really want to have sex with you. You may not be activated that much because the mind will not be there. Someone will tell me that for men maybe it may be different, because for men the whole thing can happen within 2 minutes, so maybe they can get back on their right track. But women, it is not like that. I think the foreplay will have to be a lot, especially when they are not even when they are not thinking about the sex and you just want to have sex with them. Then definitely vaginal dryness there you have. Yes, that's why there is KY, those things there to help. When there is a prolapse, like when there is a prolapse, like this thing that you have here, like this thing that you're having here, of course that one can be corrected. So they have to put it back. The ligaments will have to be. So you are that something there was a support system, and everything has broken down. So you have to make sure that you secure the supports. So surgically, so they can repair all those ones. So heteropexy, so everything can be corrected. Whether is you see, it's not only the uterus fall into the vagina. You can also have the bladder. You can also once there's a prolapse, what we are saying is that it can be surgically corrected. It can be surgically corrected. So once again, was just showing you the perineum, the gynecological perineum, where we have the perineal body. So these ones are not something that yes, of course, then the episiotomy, where they have to, enlarge the vaginal orifice. They have to enlarge the vaginal orifice. So the midline and the mediolateral episiotomy. Of course, you can from here when they are cutting. Of course, you can reduce the structures that will be involved. That will be involved. So just here is the bulbospongiosus muscles, which is set in the perineal body. The external anal sphincter inserting the transverse perineal muscles inserting there. The muscles that you are seeing here are the muscles of the pelvic floor. The muscles, the levator ani, and the coccygeus muscle. The levator ani and the coccygeus muscle. Finally, let's just do. Finally, let's look at the breast. Yes, very important. So let's look at the breast. Let's look at the breast. So that's it you have here. Now I'll talk about the breast because it's also very important when it comes to the female reproductive system. Hey, Asemo. Oh, everybody. So that's the breast. The breast is actually a modified sweat gland. So within the breast, you have the glandular tissues that will produce milk. Then of course you have fats, adipose connective tissues, which largely which determine the breast size. Of course, the breast size is also determined by your genes. Then of course you have blood vessels, nerves, and lymphatic vessels. Okay. Now so let me try and see whether you see this one here. There's something that we call the milk line. So there's the milk line. So we are saying that the breast developed from the mammary ridges or the milk lines, and the milk line extend all the way from the axilla to the groin. So what it means is that additional breast or nipple may form anywhere along the milk line. So if you look at here, there's a nipple here. The person had this nipple here. So you have these terms related to what? So polytenia, more than one pair of what nipple. Polymastia, more than one pair of what breast. Amastia, absence of breast. Then also you can have absence of what? Nipple. So yes, this is where the make line is. So anywhere you can have these what forming. Now we know what. So let's look at it when you make a section of the breast. But then anatomically, let's get some few things. So the breast extends from the sternal end to the mid-axillary line. Then, so that's the transverse. Then it also stands from the second rib to the sixth rib. So vertically from the second to the sixth rib, then horizontally from the sternal edge to the mid-axillary line. Okay. Now the breast sit on this muscle here, largely the pectoralis major muscle. You have few parts on the serratus anterior muscle. So within the breast, you have these are the glandular tissues that we talk about, and these are the fats, and these are the fats. Now, if you look at the glandular tissues, the glandular tissues are actually we have about sorry for this one. We have 15. It's not logo. 15 to 20 loops. 15 to 20 loops. So if you have this one here as a nipple, so they are arranged radially like this. So you have about 15 to 20 loops. You have 15 to 20 loops. The lobes are divided into lobes. I repeat, the lobes. So this one is not good. The lobes are divided into lobes. The lobes are divided into lobes. The lobes are divided into lobes. Okay, this is not the... Okay. The lobes are divided into into lobes. Okay. So the lobes are technically the functional unit of the breast. The lobes are technically the functional unit of the breast. If you want to be very specific, we talk about the terminal duct lobular unit. The terminal duct lobular unit is the functional and histopathological unit of the breast. But then, of course, if you don't want to look at it that way, the lobes are divided into lobes, and the lobes will constitute the functional unit of the breast. Now, these 15 to 20 lobes of glandular tissues, you see that they are separated by this white thing that you are seeing is what we are calling the suspensory ligaments of the breast, or the Cooper's ligament. The suspensory ligament of the breast, or the Cooper's ligament. You can see that they extend from the dermis of the skin and to the pelvic fascia. This is the pectoralis muscle. So the fascia around the pectoralis muscle is what we call the pectoralis fascia. So this is the pectoralis muscle. So the fascia, there is the pectoralis fascia. So this Cooper's ligament, or the suspensory ligament of the breast, we are saying that it extends from the dermis of the skin and attached to the Cooper's ligament. They are the one that actually separate the breast into lobes. Their main job is to, as it were, support and maintain the breast shape, and also prevent ptosis, breast sagging. It also prevents ptosis, breast sagging. Now, if you look at each lobe of the breast, it's drained by a duct, the latifolous duct. Each lobe is drained by a latifolous duct. And the latifunous that expands, this expansion here, we call the latifunous what? Sinus, before it opens at the nipple. Before it opens at the nipple. So the latifunous that's draining the lobe, then latifunous sinus then opens at the what? At the nipple. Okay. Now let me say something here about two signs, diagnostic signs if there is what? If there is breast cancer. The Cooper's ligaments, when there's a cancer, the tumor can infiltrate the Cooper's ligaments. So when the Cooper's ligament is involved, it leads to fibrosis and shortening. And that one is the one responsible for the dimpling of the skin around the breast. Okay. Then of course it can also, when this one too, what do you call it? If the latifunous that are involved, then of course it's going to cause what? Nipple retraction. Now, when there's the tumor cells within the lymphatic vessels, they cause obstruction. It can also produce this thing here. You see that the breast looks like the orange peel, what they call the pear the orange. The pear the orange. This is due to these cancer cells infiltrating, causing lymphatic obstruction. So there's going to be edema. It's going to be edema. Then of course you realize that the cancer cell is also affecting the Cooper's ligament and causing fibrosis and shortening. So with edema and shortening, then of course you're going to have this dimpling, and that one is going to give you that orange peel appearance. So that point is also important. If you look at this one here, you realize that the breast can be divided into quadrants, to 4 quadrants. So there's an upper lateral quadrant. In the upper lateral quadrant, you see that there is a part, in the upper lateral quadrant, there's a part that extends into the armpit. So the part that extends into the armpit is the axillary tail of the breast, or what we call the tail of Spencer. The tail of Spencer. The axillary tail of Spencer is a small superolateral extension of the breast into the axilla. When I say superolateral, it is the same as upper lateral. Okay. Now, about 50% of breast cancer cases occur in this upper lateral compartment. So it means that when you're doing breast examination, that is why the axillary tail should also needs to be assessed. Then finally, you have the nipple areola complex. The nipple areola complex, of course. So that is the nipple, that is the areola. That is the dark pigmented part. You realize that the areola contains what we call the areolar glands. The areolar glands. The areolar glands are modified sebaceous glands. So secretions prevent the nipple from from cracking. It has antibacterial also effects. Now, when it becomes enlarged, on the surface, you find some bumps here, something like these ones here. Those ones are what we call the Montgomery tubercles. The Montgomery tubercles. So the glands are what you are seeing on the inside. The tubercles are what you are seeing on the outside. Now, the nipple is located at the fourth intercostal space in males and in young females. But of course, the position will vary. Some women, their nipple is somewhere even in their thigh. So anatomically, the nipple is at the fourth intercostal space. At the fourth intercostal space. Now, for your information, the mammary gland, the milk that it produces, the way the milk is released is by both apocrine and merocrine mode of secretion. The proteins in the milk are released by the merocrine mode, and the lipid component of the milk is released by apocrine mode. You did this one in first year when we were looking at exocrine glands, that there is a holocrine, merocrine, and apocrine mode of secretion. The merocrine mode of secretion is where is that the commonest, that is like exocytosis. Exocytosis. And apocrine mode of secretion is where you have something like kind of burden. So if this one is the cell, and let's say these are the secreting units, a portion of it will be pinched off. So this part here will be pinched off and contain the secretion. That will be apocrine. In merocrine, you have the cell here. Then this is the secreting This is a vesicle containing the secreting material. So that one will attach to the cell membrane. Then the secretion will be released. You know that one in physiology, exocytosis. So remember, that is why they have been saying that, the breast is an apocrine gland. Then now we know that when we say it's an apocrine gland, we are talking about how it releases the breast. But now we know that it's not only through the apocrine mode. It's the lipid component that are released that way. The protein component are released by merocrine secretion. Then this one I saw it in your book, and it's very important. I see it. You can, if you look at, so here, let's say we are looking at the lobe, and this one is the secrety, the breast. See this one here. These are secrety units, the alveoli. You see, they are surrounded by myoepithelial cells. These are epithelium behaving like smooth muscles. So when these myoepithelial cells contract, they help to release the secretions. They help to release the secretions. Then watch here, the developmental milestones. So this is mature but inactive breast. In an inactive breast, you have very little granular tissues. You have a lot of fat and a lot of ducts. Then when you are pregnant, then you have the alveoli. The alveoli. Remember, when we say alveoli, you should understand. In first year, when we were looking, we said that this is how a secretory endocrine gland will look like. This is the ducts, and this one is the secretory portion. And the secretory portion, I think you were told that you have a tubular shape. It can be tubular, or it can be acinar or alveoli. So it's the secretory portion are shaped like grapes. So we call it alveoli. Okay. So in early pregnancy, under the influence of hormones, you see there's proliferation. Look at it. There's proliferation of and branching of the ducts. And then of course the alveoli begins to form. Then of course in mid-pregnancy you have a lot of the alveoli there. The lumen dilates. So then of course in the third trimester you begin to have some breast milk inside. So this is the breast at the lactating phase, containing some breast milk. Then of course after post-weaning or when you reach menopause, you have regression of the alveoli and the ducts by apoptosis. Then you have a lot of the spaces being occupied by connective tissues and fats. Okay, so that is the breast for you. Then still on the breast, the blood supply to the breast, you can see it here. This is the internal thoracic or the internal mammary artery. Is the one the supply giving branches to supply the breast. Then there's the axillary artery giving the lateral thoracic. Those are the chief blood supply to the breast. The other sources to the breast. The venous drainage will follow the artery. Of course, in terms of innervation, they will be innervated by the intercostal nerves because you see the breast in the chest, so dominated by intercostal nerves. Okay. We know that within the breast, milk ejection is under the hormone oxytocin. So the oxytocin is what's going to act on the myoepithelial cells. And the milk production is by hormone prolactin. By hormone prolactin. The development of the breast and the ducts and the alveoli is due to estrogen and progesterone. So estrogen, so you realize that in your menstrual phase, during the proliferative phase after menstruation, during the proliferative phase, that is when, under the influence of estrogen, that is when there is proliferation of the ducts. Then after ovulation and you are in the luteal phase, or the luteal phase in the ovary, then the secretive phase in the uterus. The progesterone that is released by the corpus luteum, it's what is going to stimulate the growth of the lobes and alveoli. So estrogen, progesterone has to do the development of the ducts and the glandular tissues. Oxytocin will be what? Act on the myoepithelial cells so that the milk can be released. Prolactin for milk production. Now, the lymphatic drainage, about 75%, they all drain to the axillary lymph nodes. And of course, if you are saying the axillary lymph nodes, start explaining why we are saying that most breast cancer occurs in the upper lateral quadrant of the breast. 75% is the axillary lymph nodes. 20%, especially those on the medial quadrant, they drain into the internal mammary lymph nodes. So what I mean is that most of the lymph vessels, they drain the medial side here, they will drain into the lymph nodes around here. But most of the breast, the lymph nodes all drain, eventually they all drain into here. You have most of all draining to the axillary lymph nodes. The axillary lymph nodes. So the axillary lymph nodes, there are plenty. There are plenty. We're not going to talk about that one. Okay, so any question? Any question we have talked about so far? Let me see whether they are still not. You should use his tongue and finger, doggy style. Can use your African breast. What? Please, can you use the African breast? African breast, like, you see, most of these images is very difficult getting. Of course, we pick them from, if we are talking about the images, we pick them from books. Most books are written by Europeans. So once we have nipple, inverted nipple, please, that one, it means that it needs to be assessed because we are seeing that infiltration of the lymph node that can cause those nipple what inversion of what the nipple. I think the golden rule is that once there is a change, you need to find out what is causing that. If there's another nipple form, there's nothing wrong. As I told you, developmentally, from all the way from the axilla to the ground, and there's a line, and the breast can form along those lines. But of course, all the other places should not. The breast shouldn't form there. But as we are saying, anything can happen. So it can happen, and when it happens, you don't need to what? You don't need to worry about it. So that sucking of breast reduces the risk of cancer. I don't know how the sucking is going to, because if you look at cancer, we talk about risk factors. We talk about risk factors. So, and genetic appear to be a very important risk factor. And for those who have runs in the family, they are the ones that are advised to be doing mammography once a year. Be doing mammography once a year. So breast milk good for men. Yes, Gary soakings and tea. Definitely your wife. You see, sometimes those who say that they are just trying to inform us that they are not married. Those who are not married, they think about that. Because there is ideal milk is there. So I'm wondering why you have Gary Garnots. So I'm wondering why you will want to make Gary soakings with a breast milk that your wife is trying to give to your baby. Which one will taste nicer? It's in the foreplay, it's in the sex mood there. Oh, then that one there, that one there you can do anything because it's not only the nipple that people suck. People suck so many places. So that one there is in the mood, in the sex mood. And in the sex mood, some people they don't think straight, especially those people who like watching porn. Whatever they learn from pornography, then they will try to do that.